Okay, Bismillah ar-Rahman ar-Rahim. Phenylketonuria with pregnancy. Okay, it's a TOG article and it came in the exam. Okay, it was discussed in the previous course and it came in the exam. It came in July 2019, so it's important. And alhamdulillah, our colleagues solved the question. Okay, that's why I tell you, the difficult questions in the exam, they come from the TOG articles. But the TOG articles is a very large source of evidence. Which one to choose? You have to select the most important topics. Okay, what is the meaning of phenylketonuria? It's an enzymatic deficiency. It's an enzyme called phenylalanine hydroxylase deficiency. This enzyme is defective. So the precursor, which is phenylalanine, will accumulate in the body because it will not be converted into tyrosine. From where phenylalanine comes? Phenylalanine comes from the metabolism of the proteins. When we eat proteins, when you eat meat, eating meat, its metabolism will lead to production of phenylalanine, which is a toxic material. Phenylalanine will be converted into tyrosine to give some useful materials, like dopamine, which is the chemical neurological transmitter. We know dopamine. It will give melanin, which is the pigment of the eye, pigment of the hair, pigment of the skin. And it will give some body proteins. So when you eat meat, phenylalanine will be produced, then it will become tyrosine to give dopamine, melanin, body proteins. By which enzyme? Phenylalanine hydroxylase. Some people are born with enzymatic deficiency. They have deficiency, sometimes complete absence of phenylalanine hydroxylase. So when this enzyme is deficient, what will happen? Okay, Dr. Dalia, can you hear me? I opened your mic.
Yes, I can.
Okay, welcome.
Thank
Can you tell me, when this enzyme is defective, what will occur to phenylalanine? Increase or decrease?
It will increase. It will accumulate.
It will accumulate. And it's a toxic material, as we said. What will occur to tyrosine?
It will be deficient.
Deficient. So what will happen to dopamine, melanin, and the body proteins?
Will be deficient too.
Excellent. When body proteins will be defective, there will be intrauterine growth restriction, SGA. And the body weight will be less than expected. When melanin is defective, so staining of the hair, staining of the skin, skinning of the eye will be defective. The color will be defective. When dopamine is defective, there will be problems in the mental and the behavioral function. You know how the pathophysiology occurred? What is the main problem? Phenylalanine hydroxylase deficiency, sometimes even complete absence. The problem. Thanks a lot, doctor. Thank you. The problem that
You're welcome.
the baby in utero, which doesn't have enzymatic deficiency, can be affected by a diseased mother. How? Let's say that the mother, the pregnant woman, has phenylketonuria. So her blood contains high level of phenylalanine. The baby is normal. The baby doesn't have enzymatic deficiency. But this phenylalanine will be transmitted through the placenta to the baby. It will be toxic to the baby. So although the baby here has no enzymatic deficiency, but the baby can be affected by excess phenylalanine from maternal circulation. Another scenario, that the baby itself, it has enzymatic deficiency. So the baby will be born having the disease, will be born having phenylalanine deficiency. So this baby will suffer lifelong. So
Can you please, Dr. Osama, repeat it again?
Again, the baby in utero can have enzymatic deficiency, so this baby itself has phenylketonuria. The baby will do harm to itself. Scenario B, the baby has no enzymatic deficiency, but the mother has a disease. This phenylalanine from the mother will be transmitted to the baby and it's toxic to the baby. Clear? Clear, doctor? The doctor
Yes,
asked you
yes.
to repeat. Okay. So in the first scenario, the baby is normal. The baby has no enzymatic deficiency, but the toxic material is coming from mama. Mama has disease. Scenario 2, the baby itself has phenylketonuria. The baby itself has phenylalanine hydroxylase deficiency. So the baby will do harm to itself. Okay, and sometimes unlucky babies will have the two scenarios in the same situation. The mother has phenylketonuria and the baby itself has also enzymatic deficiency. So will receive phenylalanine from mama and will produce itself excess phenylalanine. So two sources of harm. This phenylalanine will lead to, very important word, irreversible damage. Irreversible damage. So can you tell me, if a woman is having the disease and preparing for pregnancy, can she have pregnancy without preparation? No. We need very good antepartum care, antenatal care, preconception care. So she should be well prepared. We need to try to reduce the amount of phenylalanine in her body as possible. This toxic material should be reduced as possible to the lowest possible. It's a toxic material. She can't be allowed to be pregnant with this toxic material accumulated into her blood. It will pass through the placenta to be toxic to the baby, leading to irreversible damage. That's why we will talk a lot about the preconception care. She should come before pregnancy. Doctor, please, I have phenylketonuria and I am preparing for pregnancy. We will measure phenylalanine level into her blood to know what is the severity of the problem. And we try to reduce phenylalanine level as possible. How to reduce it? By avoiding food containing phenylalanine. So we will prevent some foods from her. But as we said, phenylalanine comes from proteins. We can give her some supplementations, which are amino acids and proteins phenylalanine free, without phenylalanine. We have these medications, but they have bad taste, but they are present. So the problem in phenylketonuria is excess phenylalanine. From where it came, there is deficiency in the enzyme phenylalanine hydroxylase. So phenylalanine will accumulate, tyrosine will decrease, dopamine will decrease, melanin will decrease, body proteins will decrease. So neurological problem, behavior problem, CNS problems, IUGR, microcephaly. What is the incidence of PKU? Is 1 in 10,000 births. 1 in 10,000 births. Okay, this is the incidence of PKU in pregnancy. How many persons in UK they have PKU? 3,000 to 4,000 persons in UK. Okay, 3,000 to 4,000 cases in UK they have phenylketonuria. So these cases we need to reduce phenylalanine level by avoiding food containing phenylalanine. And if this woman is preparing for pregnancy, she should be prepared by reducing phenylalanine containing foods. So we reduce the level of phenylalanine so she can get pregnant and no harm occurs to the baby. But take care, the baby can inherit the disease from the mother. Phenylketonuria is an autosomal recessive problem. So let's know what is the meaning of autosomal recessive. Autosomal recessive. We know that each character is presented by two alleles. Let's say the character here is phenylalanine hydroxylase deficiency, or PKU. If you have one affected gene, it's autosomal recessive. You are a carrier. Because autosomal recessive characters, you need to be homozygous to have the disease. If you are heterozygous, you have one affected gene, you are a carrier. So one affected gene, and also the other gene is affected, you are now a patient. Homozygous. If both genes are normal, I always mark the affected gene by this dot. If you have two normal genes, you are a normal person. So let's say that the couples, the father is a carrier, the mother is also a carrier. I will select a mic. Okay, Dr. Dalia. So we have the couples here are carriers. Dr. Dalia, you can hear me?
Yes, doctor, I can hear you.
If the coming baby received this gene and this gene, what is this?
Affected.
Excellent. Two affected genes. This is a patient. So this baby will suffer in utero. The baby will do harm to itself. Right?
Right.
Okay. Scenario B. This gene with this gene. So it will be one affected and one normal. What is this?
Carrier.
Carrier. Okay, we finished this one. Let's go to this one. This one with this one. What is this?
Another carrier.
Carrier. Excellent. The last possibility, this one with this one. So it will be like this. What is this?
This is non-affected, normal.
Normal person. Excellent. So 50% carrier. This one carrier, this one carrier. 50% carrier. 25% patient. 25% normal. And this is the result for any couples who are heterozygous or who are carriers for an autosomal recessive disorder. 50% will be carrier, 25 patient, 25 normal. Okay, is it difficult? Somebody wants me to repeat? Okay, I will allow mics to be open. Repeat. Autosomal recessive. The same will be used if we are talking about sickle cell disease. It's autosomal recessive. The same if you are talking about cystic fibrosis, autosomal recessive. The same if you are talking about thalassemia, it's autosomal recessive. Okay, repeat. Okay, we have here the couples. Let's say one of them carrier, the other one is normal. Here to here, carrier. Here and here, carrier. Here and here, normal. Here and here, normal. We are talking about autosomal recessive disorder. What is the meaning of autosomal recessive? One affected gene is not sufficient to be a patient. If you have one affected gene, you are a carrier, not a patient. To be a patient, you should have two affected genes. Another example. But now let's talk about autosomal dominant. What is the meaning of autosomal dominant? One affected gene is sufficient to have the disease. So, what is this? Patient. Patient. There is no carrier in autosomal dominant. Because having one affected gene, you are a patient. There is no carrier. And this one, normal. To make it easy, as long as this one homozygous, so this one will give normal gene to all new generation. Here to here, patient, there is no carrier in autosomal dominant. Patient, here to here, normal. So 50% normal and 50% will be diseased. Autosomal dominant. Always, when we talk about autosomal dominant and this person is diseased, we usually say this one is heterozygous because having one affected gene is sufficient. He doesn't need to have two affected genes. Only one is sufficient to be a patient. Okay, easy? You can open your mics. Easy?
Yes.
Okay.
Yes.
Easy for dominant and recessive. PKU is dominant or recessive?
Recessive.
Recessive. What is the enzyme deficiency? What is the name of the enzyme?
Phenylalanine hydroxylase.
Excellent.
Deficiency.
Phenylalanine hydroxylase. So what is the material that will accumulate into the body and it will be toxic and it can pass the placenta to the baby and pass even by active transport against the concentration gradient? What material will accumulate? What is it?
Phenylalanine.
Phenylalanine. So what materials will be defective? Which are important?
Tyrosine.
Nerve, color of the eye, color of the skin, and for body growth. What are these three materials?
Melanin.
Melanin, the neurotransmitter, dopamine, and the body growth.
Dopamine
Excellent.
and protein.
Excellent. From where comes phenylalanine? From food. Some food are containing phenylalanine, like what? Let's see the list. I will mute mics. Okay, like fish, like milk, like meat, dairy products, wheat, eggs, diet soda, nuts, legumes, they contain phenylalanine. So we will avoid these types of food in PKU patients. And we will give them low protein food because it has low phenylalanine level. But they will have protein deficiency. Like this, we can give them protein supplementation medications without phenylalanine. They have bad taste, but they are good source of proteins without phenylalanine. As we said, we have two scenarios, that the mother is doing harm to the baby or the baby is doing harm to itself. Here, the mother is doing harm to the baby. The mother is sending phenylalanine to the baby in utero. The bad news, against concentration gradient. So the amount in the baby can be up to 2.5-fold the concentration into maternal circulation. So we'll take phenylalanine, it's toxic material. So IUGR, microcephaly, congenital heart disease, intellectual and developmental disability, facial dysmorphism, abnormalities in the face growth, and eczematous rash. These manifestations, they resemble very important word, fetal alcohol syndrome. the problem. It's difficult to discriminate. The neonatologist, is it phenylketonuria to the baby or this is fetal alcohol syndrome? So we need to investigate. It's similar clinical picture in the newborn. It's important point. Or the baby itself can have the enzymatic deficiency. So we'll have similar manifestations on the long run. Microcephaly, epilepsy, okay, abnormal body odor, eczema, decreased hair pigmentation. They are manifestations of decreased dopamine, decreased melanin, decreased body proteins. Intellectual and behavioral problem. Why? Dopamine deficiency. MRI, even the brain can be affected. So the baby can do harm to itself. How? The baby have enzymatic deficiency. Or the baby can be harmed from the mother. How? The mother has a deficiency. Sometimes you can find both. Okay, the mother and the baby both have the disease. Okay, as you see here in the picture, abnormal color of hair, abnormal color of eye, microcephaly, decreased growth, mental problem, behavioral problem, CNS problems, epilepsy, and structural brain damage. So how to treat? You have to reduce this toxic material as possible. And we have critical times in life in which in these times in the life you should reduce phenylalanine. What are these critical times? To the embryo. How? To control phenylalanine level into the mother. Treat the mother preconception, so that you are reducing the amount of phenylalanine which can transfer through the placenta to the baby. When this baby is born, until the first 7 years of life, very important. Phenylalanine will do extreme harm to the brain in this age. Women preparing for pregnancy, why? I want to protect the coming embryo. And during pregnancy, why? I want to protect the embryo. So, in females, preconception care is important and antenatal care is important. In the baby, as an embryo, protect this embryo by treating the mother. And after delivery, until 7 years, very important. This is the time of brain growth, the time of development, the time of behavioral experience. It should be controlled at this time. After that, after 7 years, not important. Already the brain is developed. Already the body is developed. Especially after maturity, after age of 17, not important to be controlled. Not important. Already the brain is developed, the body built already is developed, everything is okay. No need to correct after 17, except if this is a female and planning for pregnancy. We need correction to protect the baby. Okay, easy up till now? Easy up till now?
Yes.
So more control is needed in females than males because of the pregnancy and the time of seeking for pregnancy to protect the coming baby. Okay. According to the enzymatic deficiency severity, we have grades. The classic form is having severe up to complete absence of the enzyme. So phenylalanine will be very increased. The normal level of phenylalanine up to 120. In the classic form, it will be 10-fold or more. 10-fold or more. 1200 or more. In the classic form. And this is the most severe form. The most severe form is the classic one. Complete absence of the enzyme. Non-classic, it will be less than this. It will be less severe. Okay? From 100 to 600, It's not called phenylketonuria, it's just called hyperphenylalaninемia. Hyperphenylalaninемia. 600 to 900 mild, 900 to 1200 moderate. The severe form is the classic one. So normal level less than 120, 120 to 600 hyperphenylalaninемia, HPA. 600 to 900 mild, 900 to 1200 moderate, more than 1200 it's severe, which is the classic form. How to treat? We want to treat the children, we want to treat the mother pre-conception, we want to treat the mother during pregnancy. Okay, the unit is mole per liter, international, or millimole per liter. I mole per liter. Okay, can't you see the slides? Dr. May? Explain on what? Okay, how to treat? As we said, number one, we need to manage women before they become pregnant. Women seeking for pregnancy should be well controlled. How? To reduce and to avoid eating food containing phenylalanine. We can give her protein supplementation, which doesn't contain phenylalanine. And we need to monitor phenylalanine level in her blood. Until she is controlled, we need contraception. How to give contraception? We will give her combined pills until she is controlled. But combined pills can do harm to the endometrium. So we will give combined pills for 3 months. Then we shift to condom. Why? To avoid the hazard of the combined pills over the endometrium. Because we want this woman to get pregnancy soon. Actually, in adulthood, control is difficult. Imagine you are avoiding eating these forms of meat, fish, milk products. It's difficult. And giving her protein supplementation with low phenylalanine, which have bad taste, actually. So difficult is control. It's a hard lifestyle. So we need her to become pregnant soon, once she is controlled. So at first, we start by combined pills, and then we shift to condom. Why? To prevent the effect of the combined pills over the endometrium, and of course, give her folic acid. Any woman seeking for pregnancy, we give her 400 microgram folic acid. It's the over-counter dose, because we have another dose, 5 milligram. It's not the over-counter. It needs a prescription. It can't be given without a prescription. 5 milligram is used in diabetic people, in obese women, in people with past history of having a baby with open neural tube defects, or people suffering from hemoglobinopathy like thalassemia and sickle cell disease, or people receiving anti-epileptics. But here we will give the routine dose, 400 microgram. What is your target? My target to have phenylalanine level 120 until 300. So I don't want it to be very normal. I want it to be on like mild, like hyperphenylalanemia. We said hyperphenylalanemia from 120 to 600. Okay, we accept up to 300. Okay, she will avoid eating food containing phenylalanine. We will give her supplementation, and we will continuously test her phenylalanine level twice per week. How? By needle prick. Then take the blood sample on a specific filter paper to be tested. Like Gaussian test done for the newborn, the same on a filter paper, put the blood sample on a filter paper to be tested to measure the amount of phenylalanine in the sample. It will be done twice per week. Once controlled, she can seek for pregnancy, but continue monitoring, continue giving folic acid. Once she is controlled, she can start seeking for pregnancy. But doctor, difficult of PKU is difficult. Preventing some types of food, giving bad taste supplementation. What if she tried to get pregnant and she failed? If the woman without contraception, 12 months, she couldn't get pregnant, refer for fertility specialist. Don't wait more than 1 year. Don't wait 2 years. No, 1 year is enough. Why? Control is difficult. So at 1 year of trying to become pregnant, if she failed to become pregnant, refer for fertility specialist. She needs help. Because control is difficult. And we want her to become pregnant while she is controlled. Okay, alhamdulillah, she became pregnant. What will be the antenatal care? Okay, what do you expect to know what you will do? We expect IUGR, small for gestational age, microcephaly. We expect after delivery, the baby may suffer from intellectual problem, developmental problem, mental problems. We expect this. So we talk about frequent monitoring of phenylalanine level during pregnancy. We are talking about frequent scans. We are talking about good neonatal examination after delivery, and even as a child should be examined to catch any developmental, intellectual, or behavioral problems, because the baby may suffer on the long run. Okay, and also we need scans during pregnancy to check for small for gestational age, check for microcephaly, check for congenital heart disease, very important number, 7 to 10%. Important number, it can come in the exam. Congenital heart disease in PKU, 7 to 10%. What is the background number? Around 2, maximum 5%. Here it's 7 to 10%. 7 to 10%. So it's increased. Why? Phenylalanine is a toxic material. Important point. Preconception. We test phenylalanine to confirm that she is controlled. How many times per week? Twice. During pregnancy, we test for phenylalanine level. How many times per week? 3 times. So preconception 2 times per week, antenatal 3 times per week to confirm that she is controlled. What if we find at any time poor control? Aggressive diet control. So you have to involve dietitian, should be involved. Metabolic consultant should be involved. How to check for microcephaly? We measure the head circumference. The head circumference. Let's say that we are now at 28 weeks. Let's say that the head circumference at 28 weeks is, for example, 4 centimeters. It's an example. 4 centimeters. We have something in statistics, we call it standard deviation. Let's say standard deviation is 0.1 centimeter. So how to define microcephaly in PKU? Microcephaly. This is a curve. What I say now will be repeated again in details in statistics, but just have an idea. So the mean is 4 centimeters. Standard deviation 0.1. The Stoke article told us that you can say that the baby has microcephaly if the head circumference is 5 or more standard deviation below the mean. So 5 standard deviation, it will be 0.5. So 5 standard deviation less than the mean, so 3.5. So at 28 weeks, if you find that head circumference is 3.5 centimeter or less, this baby has microcephaly. Let's say at 32 weeks, the normal, the mean is 6 centimeter. And again, standard deviation 0.1. So 5 standard deviation will be 0.5. So head circumference less than 5.5 centimeter is microcephaly. Okay? So in the exam, he can give you this question. That the mother has phenylketonuria. At 28 weeks, the mean head circumference is 5 centimeter. Standard deviation is 0.1. This baby has normal head circumference, microcephaly, macrocephaly, and so on. So you will calculate to see if the head circumference in this baby is less than 5 standard deviation of the mean or not. So a question like this, it will hit 2 topics in the same time, PKU and statistics. Like the common question about obesity, okay, and statistics. It's common question. He asks about what percentage of cases who are obese, and he will give you the mean, he will give you standard deviation, you will calculate. This question hits 2 topics in the same time, obesity and statistics. We will be trained how to solve it in statistics. What about the delivery? Is it affected? No, not affected at all. The woman can deliver on the suitable time by suitable method, cesarean or vaginal. The method and the timing is not affected by PKU, as long as it's well controlled. What about breastfeeding? Okay, I will repeat it again, Dr. Nadia. So she can deliver vaginal or cesarean, no problem. In the due date, not affected by PKU. Can she perform breastfeeding? Yes. But Dr. Osama, the breast milk has phenylalanine. Yes, you are right. But it's a small amount. So breastfeeding, if you measure risk-benefit, it's more beneficial. What if this woman doesn't want to breastfeed? Okay, we have milk formula which has low phenylalanine. You should ask for, please give me milk formula with low phenylalanine. It's present. But generally, breastfeeding is allowed, no problem. After delivery, the baby should be examined by a neonatologist, and on childhood should be examined for any neurological problem, for any mental, for any behavioral problem. The baby will be even seen by psychologists at 1 year and a half, 4 years, 8 years, and 14 years, searching for what? Any cognitive, any mental, any behavioral problems. Any questions about PKU? Don't forget, we check phenylalanine pre-conception 2 times per week. During pregnancy, it's more serious, 3 times per week. Don't forget, we need combined pills, then condom. Why combined pills? To have regular menstruation, to confirm that she is not pregnant. If you give her POPs, progestin only pills, she may get pregnant while you are giving it and you don't know, because you are not waiting for withdrawal bleeding. That's why we give combined pills, to have regular withdrawal bleeding. Okay, don't forget, control is important pre-conception, antenatal, in the newborn, in the childhood. After 17 years, no problem. Except if this is a female seeking for pregnancy. Okay, you can open your mics if you want to ask. Questions? Is it easy? It came in the exam before. It's a TOG article 2018, last year, 2018. Yes, Dr. May, you can open your mic and ask. Dr. May, you can open your mic. You can open your mic. Is this will meet? Yes, yes. I will send this lecture on YouTube as free. It's a gift for all candidates. It will be present. And I will post it on my Facebook also. It's a gift for everybody. Okay, and also
thank you, doctor.
Thank you. And also the orientation session will be sent also on Facebook and YouTube. Okay, you can find, okay, somebody asked it again about how to calculate head circumference according to this article. This is a curve. Let's say that this is a curve for head circumference at age of 32 weeks. Let's say that the literature said that the mean head circumference is 6 centimeters. And the standard deviation is 0.1 centimeter. So the mean is 6. 1 standard deviation equal 0.1. The guideline said we care if 5 standard deviation less than the mean. 5 standard deviation, it will be 0.5. So 5 standard deviation, so 0.5 less than the mean. So 6 minus 0.5, it will be 5.5. So 5.5 or less, this is microcephaly at this age. Okay, to describe any normal distribution curve, you should know what is the mean and what is the standard deviation to be able to describe and draw the curve. Let's solve these questions. Okay, this black box, they are your names, and it's the chat. And I always put it away from the writing. Okay. Okay, you can write the answer on the chat. First question, regarding PKU, it's deficiency of phenylalanine. Deficiency of phenylalanine, true or false?
False.
False, you are right. What is the correct?
Phenylalanine.
Excellent.
Increase.
Excellent, and increase in phenylalanine. Excellent. It's X-linked recessive.
False.
False.
What is the correction?
Autosomal recessive.
Autosomal recessive. Excellent. It will result in tyrosine deficiency.
Yes, true.
True.
Yes, true.
You are right. It's treated with phenylalanine restricted diet.
True.
True.
True. You are right. And even we can give her protein supplementation with low phenylalanine level, but they have bad taste actually. That's why control is difficult. The incidence is 1 in 1,000.
False.
False. It's 1 in 10,000.
10,000.
10,000.
You are right. The newborn screening program has great success in diagnosis and management. Of course, this is true.
Yeah.
True.
True, of course. Neonate with fetal alcohol and PKU are clinically difficult to distinguish a person.
True.
Yes. True.
This question came in July 2019. It came a few days ago in the exam. Right, Dr. Hannah? Do you remember the
Right.
question? Okay,
Right.
don't say it. Okay. In utero,
Irreversible damage.
in utero,
Irreversible damage.
in utero, exposure to high-level phenylketonuria is not in reversible damage. No, it's irreversible.
False. Irreversible.
That's why we don't play with controlling pregnant women and the preconception. We don't joke in this point. We need aggressive control, but not to have normal phenylalanine. We allow a slight increase up to 300. Pregnancy outcome is improved when you have low phenylalanine in the mother.
Yes.
True.
Yes.
This is your target.
True.
This is your target. Oral contraception should be switched to a condom 12 months before conception. 12 months?
6 months. 3 months.
6 months.
3 months.
3 to 6 months. The risk of congenital heart disease up to 10%.
True.
True.
Right. Up to 10%. It's an indication for early delivery by CS.
False.
False. It doesn't
False.
affect the mode or timing of delivery.
Yes.
Neonates born to mothers with PKU should be offered screening for PKU as routine. Sure.
No.
Sure. We need routine
True.
screening.
Yes.
Sure. Breastfeeding is contraindicated.
False.
No.
False. It's allowed. Although breast milk has some phenylalanine but in low amount. What if the woman doesn't want to offer breastfeeding? Okay, we have phenylalanine-free breast milk, free milk formula. Phenylalanine is passively transported.
False.
Active.
Active. That's why it can pass against concentration gradient.
Gradient.
So it can even be 2.4, 2.5 times greater in the fetal than maternal level.
Yes. True.
Children born to women with PKU, they tend to have blue eyes because there is defective melanin. Yes.
True.
They have fair skin, defective melanin also. True. Excellent. A mother is having PKU syndrome. So the mother has a syndrome. It's autosomal recessive. So she is homozygous. The father is normal. Okay, when the people are homozygous, okay, so this woman will give this gene for all children, and this man will give this normal gene for all. So all the new generation will be
Carrier.
100% will be carrier. 100% will be carrier. The question asking about how much will have the disease?
Zero.
Excellent. No one will have the disease. They will be carriers, but they will be healthy. 0%. Excellent. So 100% carrier, 0% will be diseased. But they can inherit the disease to the new generation.
Yes.
Okay, any questions about PKU? Any questions? Because we finished. Any questions? You can open your mic and ask.
Inshallah, Dr. Osama, the first lecture next Friday.
19th July inshallah. 19th July. This is the next meeting inshallah. It will be the first session on the course. Okay, today this is an orientation session, so I will repeat again. PKU, because today is just a gift for our friends. So it will be repeated again.
Thank you, Dr. OSAMA.
And we will have also systemic lupus with pregnancy in day 1, inshallah, which will be 19th of July, inshallah. Okay, the lectures today will be uploaded on YouTube and on Facebook. It will be available free for everyone, the lectures of today. Of course, I'm not talking about lectures of the course. I'm talking about the orientation session today. Okay, thanks a lot. And
thank you, Dr. OSAMA. Thanks you.
Presence today. Thank you. And best wishes for everybody. Thank you.
Bye-bye.
Thank you very much. And I want you to feel hopeful. It's not difficult to prepare for the exam, but you need to be working hard. Okay? Thanks a lot.
Okay, no. Thanks.
Thank you. Please, if somebody has questions, you can contact me on WhatsApp. On the number I give you, 002 0100 806 7383. This is my WhatsApp number. Okay? Thank you and Assalamu alaikum.